anything that can cause heavy bleeding. Fibroids, yes. Anyone else? Anyone? Endometriosis, yep. Okay, so when I did it, I tried to categorize them. So I came up with, copper coil. Yes, that is a really good one, Ella. Copper coil. Bleeding disorders, also a good one, Ella. So I came up with growth. This is a really terrible category, but I couldn't think of what else to call it. So things like endometriosis, fibroids, uterine cancers, and polyps. Then infections, so pelvic inflammatory disease and STIs sometimes can, but more commonly pelvic inflammatory disease. Iatrogenic, so anticoagulants, and then the IUD, so the copper coil, one of the side effects is heavy periods. So that is something important to make sure you think about. It's also something important to counsel a woman about when you give them an IUD. Hormonal causes, so PCOS, which is polycystic ovarian syndrome, obesity and hypothyroid can also cause it. And then coagulopathy, so like bleeding disorders. So the one I came up with is von Willebrand disease. Okay, then dysmenorrhoea, which is painful periods. Again, can anyone think of anything that can cause painful periods? Pelvic inflammatory disease, yep. Anything else? Endometriosis again, yep. So I came up with, again, growth, so endometriosis, adenomyosis, fibroids and Asherman's disease, then infections, so STIs and pelvic inflammatory disease, and then iatrogenic, so also the copper coil can also cause painful periods as well as heavy bleeding. Okay, so the first condition we're going to start off is endometriosis. So, Eleanor, do you know, or anyone, does anyone know what endometriosis actually is? Okay, so it is a chronic inflammatory condition which is caused by the presence of endometrial tissue outside of the uterine cavity. So the actual cause of it is unknown. There are lots of different theories, like retrograde blood, like flow of period of like menstrual blood, and loads of different theories, but generally there's no actual concrete reason, like known cause. So there is a slight link in that you have an increased risk if there's a family history, but other than that, there are no real identified risk factors. So basically, the ectopic endometrial tissue is found usually in the pelvis. So the most common locations are the pouch of Douglas and the urosacral ligament. But you can also get it in the peritoneal lining, ovaries, and retrovinal septum. And then rarely you can get it in the abdominal cavity and like the diaphragm and that kind of thing, but that's very uncommon. But it can present there if you in weird situations. Okay, and also in the eye, according to Anish. So most commonly it is in the pelvis, but in very rare and probably more severe situations, it can be everywhere. So basically what happens is the ectopic tissue responds to cyclical hormonal changes, so it undergoes cyclical bleeding, and this basically causes repeated inflammation, which gives symptoms. And there's also episodes of repeated bleeding, and then healing lead to fibrosis and adhesions, and that also gives you the symptoms. And then it's important to note that you can get something called an endometrioma, which is also known as a chocolate cyst. If anyone's ever heard of that, it's a slightly disturbing name. And basically, that's found on the ovaries, and it's a characteristic of endometriosis, and it basically enlarges with blood during every cycle. Okay, so symptoms. Anyone think of any symptoms, given the fact we've just gone over 2 of them? Any symptoms, anyone? Dyspareunia. Yep. So dyspareunia is painful sex, and it is painful deep sex, basically. So it's not superficial. So you get pelvic pain, which can be constant or it can be cyclical. And you get cyclical pain in your periods, which usually starts a few days before your period starts and then peaks like while you're on your period, which is characteristic of endometriosis. Then you can get deep dyspareunia, which is basically deep pain during sex, and you get subfertility. So some women may present with having difficulty conceiving. Then yes, so Valeria is right. You can get dysuria and pain on passing stool. So this is when you have involvement of like the bowel tract and the urinary tract. So it's not super common, but it can happen. It's more in more severe cases. So on examination, you usually get pelvic tenderness, and then you get nodularity. So these are nodules depend on where the endometriosis is. So you can get uterosacral ligament nodularity, nodules in the pouch of Douglas, nodularity in the posterior vaginal fornix, and then you can also get this mass, which is the endometrioma I talked about. And then really late stages, you get like a fixed pelvis. So basically, because the adhesions and scarring is so bad, the uterus is immobile and doesn't move, and it's like fixed in place, that's in much more severe cases. So to investigate, you would do an ultrasound and MRI. Most of the time, these don't really show much. So you might occasionally see like some endometriosis and adhesions or an endometrioma, but they're not the most helpful tests. So the most helpful thing to do is a laparotomy and a biopsy, and then you can actually see the endometrial, like the excess ectopic tissue in the uterine cavity. Okay, management. Can anyone think of how the management might differ between fertility being desired and not desired? So yeah, people are saying if undesired, you can offer the oral contraceptive pill, and you can do hysterectomies if it's not desired as well. So if fertility is desired, we'll start with that. The first thing, so there are slightly different orders to the way you would do this, and it kind of depends on, because lots of GPs won't normally diagnose it, so they might not be referred down the typical pathway. But you can do a therapeutic laparoscopy, sorry. So you basically open up the abdomen and you try and remove as much of the like adhesions and scar tissue as possible in the hopes that it will improve the chance of conceiving. If that doesn't work, you can use controlled ovarian hyperstimulation. Clomifene is the most commonly used one, and basically I'll come on to it later in one of the other sections, but it encourages like ovulation, and then if that doesn't work, you can use IVF, which obviously gets around the issue of like ovarian tube scarring and that kind of thing that you often get with endometriosis. So if fertility is not desired, as Rita said, you can start with contraception. So you give NSAIDs for the pain because it's like an inflammatory pain, so NSAIDs work quite well. And then you can also give the combined oral contraceptive pill or progesterone-only contraception. So some people might prefer the progesterone-only because you have no breakthrough bleeding. So, and often the pain is associated with bleeding, so you get no breakthrough bleeding. That doesn't work, you can go to laparoscopy. And then if that doesn't work, or in the run-up to surgery, you can use GnR agonists or antagonists and androgens. So the GnR agonists, basically they suppress the release of LH and FSH, so there's no estrogen and progesterone produced at the ovaries, and that basically causes hypogonadotropic hypogonadism. But side effects of this usually mean that you have like low estrogen, which then can cause loss of bone mineral density, so they're only advisably used for 6 months, so they're not like a long-term solution. So you might, for example, give that to a woman before she has surgery. And then androgens can cause an hypoestrogenic state, which will suppress the release of LH and FH and basically causes amenorrhoea, so you don't bleed, because obviously the pain is associated with bleeding. And then if a woman definitely doesn't want children, or she's completed her family, you can consider doing a hysterectomy. Obviously, this is like a life-changing procedure, so it's like not something that you do first line, and it's not something that's done on a whim. It's like a big decision for a woman to take. and it has got to be like signed off by 2 consultants and that kind of thing. And Anisha's asking if anyone knows how long it takes to reach the average diagnosis of endometriosis, which is apparently 8 years, which is actually horrendous. So it's not a very common condition. Sorry, it's not. People don't think it's a very common condition, but it's not very well diagnosed. Okay, so does anyone know how endometriosis differs from adenomyosis? Yes, so adenomyosis is endometrial tissue basically within the myometrium. So what happens is you get ectopic endometrial tissue is found in the deep in the underlying myometrium. So you can see here all these little spots, the dark spots within the within the uterus, like wool. And basically that's what happens in adenomyosis. So rather than the ectopic tissue being found like outside of the uterus, it's found just in the wrong place within the uterus. So the inner lining of the uterus, which is the endometrium, basically breaks through the muscular wall and is found in the myometrium. And they don't really know what the cause is. So it's caused. The symptoms are, as I said before, like menorrhagia and dysmenorrhea, and then you can also get pelvic pain again and deep dyspareunia. And then characteristically of this, you can get a large boggy uterus because you get excess basically tissue in the uterus. So it might be like in an SBA, you might have a classically enlarged boggy uterus. And Anisha's saying that the theory for this is very interesting. You get micro injuries to the myometrium, like during pregnancy, basically, and it heals badly, which causes the endometrial tissue to deposit there. So investigations usually do an MRI, which will basically show thickening, although it can be like unspecific. So you can also do a biopsy. So that can either be like through a hysteroscopic biopsy, or you can do it as a laparoscopic biopsy, and you will basically find the endometrial tissue within the myometrium. And the management I haven't written out again because it's very similar to this. It basically differs depending on whether you want to conceive or not, which is what you'll find for a lot of like gynae conditions. The management is basically dependent on whether the woman wants to have children in the near future. Okay, so fibroids. Fibroids are, does anyone know what fibroids are? Any ideas? Okay, so fibroids are benign tumours of the uterus that are comprised of smooth muscle and fibrous connective tissue. So they have this really fancy name here, which I can't say, so you can just see the fancy name next to it. And basically, classically, they are estrogen dependent, but the exact cause of them is not known, so no one knows why they happen. They're associated with estrogen. So they enlarge during pregnancy and in response to hypoestrogenic states. So, for example, if you're on the pill, and they normally shrink after menopause because there's a reduction in estrogen during menopause. So they are classified. They are more common in Afro-Caribbean women. That's very common in hospitalizations, but also it's common in real life. So when I was on ONG, I think I saw like 3 or 4 women with fibroids, and I saw 4 women with fibroids, and all 3 of them were Afro-Caribbean. No one knows why, but it's much more common in that ethnicity. So there are 3 different types. So there's intramural, which is confined within the myometrium. So that is, I don't know, can you see my mouse? I don't know if you can. I don't think you can. That is so that's actually in the myometrium. And that is, I'll come on to your question in a second, Rita. And those are the most common type. So intramural is the most common type. Then you have submucosal, which is underneath the endometrium. And these tend to protrude into the uterine cavity and distort the cavity. So these can make conceiving difficult because if you look at the diagram, you can see it sticking into the uterus. So they can cause problems with conception. So if a woman's got a fibroid and she's struggling to conceive, it's probably going to be a submucosal, but not always. And then you can get subserosa, which protrudes under the serosa, and that's the outer surface of the uterus. So you can see here, it's like on the outside. And then you can also get ones which are called pedunculated, and these literally like stick out. Yeah, these literally like stick out on, it's not on my diagram, but they stick out on top, all the sides of the uterus. So Rita has asked if fibroids potentially cause bleeding during pregnancy. Yes, they can, and there's something called like fibroid degeneration, or like a red fibroid. I can't remember the exact name of it. And basically, what happens is the blood supply to the fibroid like becomes insufficient during pregnancy, because like the blood is directed to other places in the uterus, and women can get like really, really bad pain, and they can get bleeding, and they can be quite unwell with it, but they don't do anything for it. So you might take a woman to hospital because she's got slightly low blood pressure and she's like not feeling very well, got fevers, really bad like pelvic pain, and it's basically due to degeneration of her fibroid, which is a common thing to occur in pregnancy. But because it's within the uterus, they usually don't do anything. They usually just like basically monitor the woman and let her ride it out, because you don't want to obviously go into the uterus while someone's pregnant, because there's going to be a high risk of miscarriage. So yes, it is common. It is a cause of bleeding during pregnancy. So that's something to be aware of. I think it's most common at the end of the first trimester or the start of the second, but I'm not sure. Anoush, do you know? Okay. So
sorry, what was the question?
I think it's the most common for the bleeding due to fibroids at the end of the first trimester or start of the second.
Yeah, I think for red degeneration, yeah, I think it's somewhere around there.
Okay, so symptoms are menorrhagia and dysmenorrhea, and then abdominal distension. This occurs if the fibroid's really big, then it's going to like stick, like you're going to get like bloating and that kind of thing. And then you can also get like an irregular uterus. So if you do like a pelvic exam, you might feel the uterus, which feels like abnormal basically. And you can also get like mass effect. So a bit like, mass effect. So you can get constipation if they're really large, and also like urinary symptoms like frequency. However, most fibroids, it's important to know, are small and asymptomatic. Like a lot of women have them and don't actually know they have one. However, fibroids are a common cause of, like large fibroids are a common cause of like really heavy bleeding. So the women in hospital with really heavy pelvic bleeding who needing transfusions mostly have fibroids. Okay, so does anyone think they know how you'd investigate your fibroids? Like, how would it be diagnosed? Any ideas? On imaging, what type of imaging? There's a specific type of imaging which is relatively good for this. So ultrasound, yes. The type of ultrasound differs depending on the type of fibroid. So basically on the ultrasound scan, you'll generally see like a large, firm, well-circulated nodule within the uterus. And fibroids, it's unfortunate, they are like well subscribed. They're like obviously a thing rather than like a dodgy looking lesion. So you can do a transvaginal ultrasound, which will help you see submucosal and small intramural fibroids. So it will help you see submucosal and small intramural ones. When you if you go in through the cervix, you can see those. Not through the cervix. If you go into the uterine cavity, basically, you'll see those. So transvaginal ultrasound. And then for the other type, so subserosa, you can't really see that way. So you usually have to do an abdominal ultrasound. So if you're suspecting fibroids, most women will receive both ultrasound types because it's easier to because each one is slightly better at differentiating different types. Does that make sense? And you can also do an endometrial biopsy. So if you're a bit concerned that it's cancer, for example, the woman's a bit older, you might be worried about cancer, you might do a biopsy. So it should be bundles of smooth muscle cells, because that's what the fibroid is made of. So if you're a bit concerned, someone might ask for a biopsy. So management, as I said, is divided into fertility desired and not desired. So if fertility is desired, you can do medical management. So you can do this is for the heavy bleeding usually. So you can give tranexamic acid or mefamic acid. Does anyone know when you would use mefamic acid over tranexamic acid? Yes. So I'll come back to the question in a second. So mefamic acid is a type of NSAID, so it helps with pain and it also reduces the bleeding, whereas tranexamic acid only reduces bleeding. So if someone's got really painful periods and heavy bleeding, you're more likely to give mefamic acid. Whereas if they've just got heavy bleeding and they're not bothered by pain, you could give either. But does that make sense? And then, so if they want a surgical option, you can do a myomectomy, which is basically where you like remove part of the uterine lining, but like not the whole uterus. So this can be done through like a laparotomy, laparoscopy, or like through a hysteroscopy, so like through into the cervix, into the uterus. But it's important to note that although it's used for desired fertility, it can make pregnancy complicated because you can get like adhesions within the uterus and that kind of thing. So it's not like a foolproof option. It may still make pregnancy or like have difficulty to conceive afterwards. So Mira is asked, I'm sorry if I pronounce your names wrong. So both types of ultrasound are first line, and it doesn't. So yes, basically, both types of ultrasound are first line. You would do both. If you suspected one type, you would probably still do both. And to be honest, most women will receive both types of ultrasounds. If you ask for a pelvic ultrasound, most women will have a transvaginal one and a transabdominal pelvic ultrasound. Normally, you get both. Like you do both anyway. Even if you're not suspecting fibroids for anything, usually you do both because both views are like complementary. So if you were suspecting it, you would go in with an idea of what you're expecting to see on each one, depending on what you thought the fibroid was. But as I said, it's difficult to know. So most of them are submucosal. And if the uterine cavity, they're having difficulty conceiving, you might suspect. Most of them are submural, and if they're having difficulty conceiving, you might suspect a submucosal one, but otherwise you're not really sure. Does that make sense? Let me know if there's any more questions. Okay, so if they are not interested in conceiving, first line treatment should be an intrauterine system, so the progesterone only coil. It's been shown to be most effective and work the best at reducing heavy periods. So that's the first line. If women don't want that, you can give the pill, either pill. Then you can also do a myomectomy, or you can do. You can also give anti-progesterone tablets, or you can give gonadotropin-releasing hormone agonists. But as I said before, these can only be used short term because they cause low estrogen, which can cause loss of bone density. So they're only a short term thing. So, for example, you might give them for a couple of months before a woman has surgery because they can help reduce the size of the fibroid, which can make surgery a bit easier. Or you can do uterine artery embolization. So basically, you stop the blood supply to the uterus, and then it results in infarction and degradation of the fibroid. However, a third of women who have this will need more treatment in 5 years' time, so it's not like the most effective method. And also, it can take a while to have an effect, so it actually takes a while for the fibroid to like shrink. And then the last option is a hysterectomy. So basically, this is if a woman definitely doesn't want children. As I said before, it's a major procedure that requires like major thought. Okay, next one is polyps. So I've kindly written what a polyp is. So it's an abnormal growth which protects from a mucosal membrane. The cause is unknown, but they're associated with high estrogen, chronic inflammation, and atherosclerotic blood vessels. And they don't respond to hormonal changes. So unlike the normal endometrium, they don't respond to hormonal changes. And risk factors for these include obesity, hypertension, and then high estrogen states like PCOS, having no children, being on HRT, or being on tamoxifen. Right, does anyone know the two different types of polyps? Any ideas? flat and flanculated. That's not what I'm thinking of. Anyone else? Okay, the different types are endometrial and cervical. So we're going to directly compare them. Endometrial polyps basically is endometrial tissue which grows into the uterine cavity. So these are within the uterus. And cervical polyps are endocervical columnar epithelium that protrudes through the external cervical os. So basically, the endometrial polyps, you are within the uterus, and the cervical polyps stick out, so you'll be able to see them on examination, which kind of gives the different symptoms. So one of them will cause post-coital bleeding, so bleeding after sex. Which one do you think causes that? Correct. Cervical does, yeah. And then one of them will cause usually like bleeding between periods, so intermedullary bleeding. Which one do we think causes that? Endometrial, yeah. So as a symptom, endometrial causes intermedullary bleeding, so bleeding between periods, and it can cause irregular periods and then also heavy periods. Whereas cervical usually causes like chronic vaginal discharge because these cells are secretory. Those cells, so they secretory, so it can cause discharge, and it causes postcoital bleeding. It might also cause bleeding after your examination. So if you do a speculum, like the woman may be bleeding during and after the speculum. So investigations for an endometrial, you will do a transvaginal ultrasound and you will see it as like a thickening and then hypoepigenic protrusion. Whereas for a cervical polyp, you just need to do a speculum exam and you will basically see it. It's just a growth, a red growth that protrudes to the external os. So you do both investigations because they could have both cervical and endometrial. And a speculum is normally just done in clinic and then you just refer them for an ultrasound. Does that make sense? And then management is a polypectomy, so you remove the polyp. And it's done by a hysteroscope for endometrial and just via a speculum for a cervical. And quite often, always the sample will be sent for histological examination, which is basically just to exclude a malignancy. Okay. Right, so we have an SBA. Now, if you read the SBA, then on Menti, hopefully you should be able to vote. If it doesn't work, please let me know. I probably won't be able to fix it because I'm not very techy, but
Did it work?
people seem to be voting. So I think it has worked.
Excellent.
Anyone else? The Menti code is in. Shall I repost the Menti code? So
Yeah, that's probably useful. It probably got lost at the top.
We'll repost it.
Also, this is such a classic exam question.
Okay, so the answer is, so the patient has endometriosis. Hopefully you got that by the fact that they've had painful periods for the last few years. They get deep pain on intercourse, and they've tried the combined oral contraceptive pill, but they're still experiencing pain. and pain when they're bleeding, and basic analgesia, so NSAIDs is not helping. So trialing a different contraceptive will not really be that helpful here. Whether you have the combined contraceptive pill or the progesterone only, women are still going to get pain, so it's not really a good option. So what you want to do is an exploratory laparoscopy. Firstly, you need to confirm a diagnosis of endometriosis, and then that is the most effective treatment method in treating endometriosis, especially if they're still experiencing pain. What you need to do is go in basically and try and remove as much of the adhesions and scarring as possible. So number 3, I have no idea how you say that. That is a GnR agonist. So you could give this while the woman waits for surgery, but it wouldn't be the next best step. The next best step is surgery. Does that make sense? So if it was like she's waiting for surgery, she's waiting for her laparoscopy, what can you give in the meantime? Then you could consider that, but you wouldn't give it as the next best step. The next thing, most appropriate treatment is the laparoscopy. So this is an androgen therapy, which you could also consider if, like, for example, after the laparoscopy, if that doesn't work. And then a hysterectomy with bilateral, basically just removing the uterus and the ovaries as a last resort. So you definitely wouldn't do that in this woman. She's 30, so it's quite young. You don't know if she's had kids or wants a family, so that's not a good option. Okay, does that make sense to everyone? Are there any questions? No questions? Please let me know if there are. The take-home message from this is that our laparoscopy is the most useful treatment for endometriosis, and as well as being the treatment, it is the diagnostic investigation of choice. So, for example, if the question was, how would you diagnose her condition, you would do an exploratory laparoscopy. So even that you can do MRIs and ultrasounds, but most of the time they won't show anything. So that's not like gold standard. Okay. Right, so we're now going to go on to intermenstrual bleeding, which is basically uterine bleeding between periods. So can anyone think of what would cause this? If you can, try and categorize it like I did for the painful bleeding and heavy bleeding. Any ideas? Cancer, yeah. Okay. Ooh. Infections, yep. So you can get firstly physiological. So women can get spotting around the ovulation date. So it could just be that. It could just be having like ovulation spotting. It's not super common, but it is a thing that can occur. Then you can get hormonal contraception. So particularly with progesterone only pills, you can get breakthrough bleeding. And after someone's had a coil implanted, you can also get breakthrough, or like not breakthrough, but you can also get bleeding, like random bleeding between their periods when they first get a coil fitted. So infection, so like someone's had chlamydia, yeah, like STIs, pelvic inflammatory disease, vaginitis, endometriosis, and cervicis are all infections that can cause bleeding between your periods. Then you can get pregnancy-related things. This is a really common thing to consider. So, for example, a woman might be having a miscarriage. It could be a very early miscarriage, but she might be having a miscarriage. She might have an ectopic pregnancy because they often present with bleeding, or gestational trophoblastic disease, which is very commonly does present with bleeding. That's one of the like signs of it. So it could be pregnancy related. Then it could be growth. So this is where the cancer comes in. So fibroids, polyps, endometriosis, and cancer. And then coagulopathies again can cause bleeding between periods. Okay, so post-coital bleeding is bleeding from the genital tract after sexual intercourse. Can anyone think of anything that could cause this? Trauma to the genital tract from intercourse. Yes, that is a good one. Ectropions, yes. So we've got neoplastic lesions, so cervical cancer and polyps. Infections, again, STIs, pelvic inflammatory disease, cervicis. Hormonal changes, so an ectropion is like a sort of hormonal change. We'll come on to it in another lecture. And then vaginal dryness, so that's particularly in elderly women, not elderly, but like postmenopausal women, where you have like vaginal atrophy that can cause bleeding, and then trauma. So postpartum, you're more likely to bleed when you're, you just delivered a baby, so kind of obvious, and then also rough intercourse. Okay, so pelvic inflammatory disease. Anyone know what this is? Any ideas?
I've returned. What was
Yeah.
the question?
What is PID? So PID is an infection of the upper genital tract in females. So it's things like endometriosis, uveitis, pelvic peritonitis, abscesses in the ovarian tubes, and it is caused by ascending spread of bacterial infection from the vagina or the cervix. So this could be due to instrumentation of the cervix, like which basically in introducing bacteria into the cervix. So things like termination of pregnancy can do this, inserting an IUD, and then gynae surgery can also cause it. So it can cause it to spread, or you can just have, as we just said, really like chlamydia or gonorrhea that's not been treated properly. Does anyone know what the most common cause of PID is? Chlamydia. Yes. So chlamydia is the most common cause, and then gonorrhea is the second most common cause. So they account for basically all the cases. But chlamydia is the most common. And basically,
does anyone know what the eponymous term is for PID that goes up to the liver? Which is kind of stupid. Have I ruined your questioning?
No, you haven't, but that's later on. Yes, you are right. It's called Fitzhugh-Curtis syndrome, and I'll talk to everyone else about that in a second. Basically, PID causes adhesion formation, tubular narrowing, and scarring. So if you've got tubular narrowing and scarring, what are you at risk of in terms of pregnancy, like a pregnancy-related complication? Ectopic pregnancies, yes. Yeah, really good ectopic pregnancies. And I forgot to say earlier, with endometriosis, you're also slightly at risk of ectopic pregnancies if you have like scarring of the uterus and the fallopian tubes. Okay, so basically the symptoms are lower abdominal pain, deep dyspareunia, so deep pain on intercourse. You might have abnormal vaginal discharge, vaginal itching. Then you can get heavy periods, painful periods, intermenstrual bleeding, and postcoital bleeding. You can also get fever and nausea and vomiting, and also malaise. So if a woman has a fever and then she comes like with these symptoms, you need to check for it. Not everyone gets it, but obviously it is an infection, so you can get a fever. So investigations. Does anyone know how you would investigate for this? Yes. So the first thing you do is a bimanual exam. And you need to have one of these three things for a diagnosis of PID. So you need uterine tenderness or adnexal tenderness or cervical motion excitation. So in an SBA, if someone presents with one of those things, that you should be thinking PID is like your top differential. And then you need to do high vaginal and endocervical swabs for culture because you need to find out what is causing it. I mean, most of the time it will be gonorrhea and chlamydia, but you need to check for resistance and that kind of thing. So if you're like uncertain of the diagnosis, you can also do a transvaginal ultrasound, which may show like thickening of the tubular walls and fluid, and then you can also do an MRI in extreme cases, which could show like inflammatory changes and thickening and fluid and scarring. So management. Does anyone know what 3 antibiotics you give to treat PID? Any ideas? Close, very close, Rita. You give IM ceftriaxone, 1 dose. Then you give oral doxycycline and oral metronidazole for 14 days. So you got that together. So basically what you do is you treat for gonorrhea and chlamydia. So the antibiotics you give treats both. So it's a 14-day course. You need 1 dose of ceftriaxone and then 14 days of oral medication with the other 2. What else is it important to do if you've treated someone for PID? Like, think of STIs in this sense. What would you do if you treated someone for an STI? Test for cure. You can do that. You don't have to do that. It's more contact tracing. So you need to treat their sexual partners, because if they've got a chlamydia or gonorrhea infection, it's likely that the person they're having intercourse with has a chlamydia or gonorrhea infection. So you need to contact trace, and then you need to test and treat their partners. And you should encourage the woman not to have intercourse until she has completed her 14 days and her partner has also completed their 14 days. And if a woman has a coil in, you should consider removing it, because it may have contributed to the infection. It may not have done, but it depends on the situation. So, for example, if the woman's had the coil for like 2 weeks, it's likely that that could have led to the PID diagnosis, and you might want to consider removing it. Whereas if she's had it for a number of years, it's probably something else that's contributed. So complications, as we said before, you can get abscesses and you can get peritonism. Then you can get tubular narrowing or scarring, which can contribute to ectopic pregnancies and also infertility. Then you can get chronic pelvic pain if it's not treated properly. And then, as Anoush said, you can get Fitzhugh-Curtis syndrome, which is basically it's like inflammation, like of the liver capsule, basically. And you get it causes a violin string. This is, you don't need to know this. It causes violin string prehepatic adhesions, which is basically caused by swelling of the liver capsule, and it presents with right upper quadrant pain. And the treatment is the same as the PID, but if someone has like abnormal vaginal discharge and right upper quadrant pain, that's what you should be thinking of. It's very niche, and I'm definitely sure it won't come up. And then you can also get hydrophalanx, which is basically where you get blockage of the fallopian tubes due to like watery like secretion, like fluid kind of things that build up. Okay, has anyone got any questions about PID before we move on? Okay, so we're going to do oligomenorrhea, which is infrequent menstrual periods with cycles of more than 35 days or less than 6 to 8 periods per year. So it's like one or the other. Anyone got any suggestions of what can cause this? Yes, PCOS. So firstly, big one, pregnancy. Don't miss that. One of my friends was in a clinic while she was on GP, and she was seeing this patient for 40 minutes trying to talk to her why about this lady hadn't got her periods. And the GP went in and was like, "Oh, have you done a pregnancy test yet?" And she was like, "No." And the lady was pregnant, and she was like, "I just spent 40 minutes being like, are you sweating a lot? Have you got high thyroid problems?" All this stuff. And the lady was pregnant. So someone will not realise it, and they may come and see you being like, "I haven't had my period for 2 months," or "my period," like they always think pregnancy. PCOS, so polycystic ovarian syndrome, ovarian insufficiency, so menopause, and also like premature ovarian failure. Hormonal contraception. So again, if you, for example, someone on the implant may not get periods anymore. Someone with a coil may not get periods anymore. Progesterone only pill, they won't get periods anymore. Then hypothalamic dysfunction. So basically, what happens is you have, oh my god, you have reduced. Hypothalamic pituitary dysfunction. What happens if you have reduced gonadotropin releasing hormone, which reduces the level of LH and FSH from the pituitary, and that causes anovulation. So basically, you stop bleeding and you stop ovulating. So things that can solve this are restrictive diet. So for example, anorexia, some like anorexic women will not get periods. So weight loss. So if you go have like a drastic period of weight loss, like quite quickly, you may stop bleeding. Excessive exercise, so like high achieving athletes may not have periods. Stress, if you're undergoing extreme stress, that kind of thing. And then also chronic diseases like uncontrolled diabetes, cancer, celiac disease, TB, inflammatory bowel disease, all of those kind of things can cause you to stop bleeding or stop having periods, basically. And then the last one is prolactinoma, which is just something to be aware of, but they'll probably present with some other symptoms and like eye signs as well. Okay, so the other one is primary amenorrhoea, which is the absence of menarche in a girl over 16 with secondary sexual characteristics or over 14 without. Can anyone think of any causes of this or any questions about what this is? Oh, sorry, I just muted myself. That is, yeah, there is a different chromosomal abnormality I'm thinking of. Can anyone think of that? Suggest that? They have webbed necks. So firstly, as I said again, pregnancy, guys. Pregnancy can stop people being, can stop you having periods. So even if you're 16 years old, you could be pregnant. I know it's like unlikely, but for example, a woman may never get a period because she gets pregnant straight away. So then pathological. So these are the ways I've categorized this. So you can have pathological with normal secondary sexual characteristics. So this could be something like genital tract inflammation. So the one that will probably, if it comes up in your OSCE, or not in your OSCE SBA, which probably won't, is an imperforated hymen. So basically a woman she gets bloating every month and abdominal pain, and she's like 17 or 18, and she's got breast development and that kind of thing, but she's never had her periods yet. It's probably in perforated hymen, so the blood can't leave the pelvis, basically. And then you can get transverse septum or absent uterus. So absent uterus is very, very uncommon, but women can have it. So that is something to consider if a woman comes in, but she's got like breast development and that kind of thing, but she doesn't have any periods. And then androgen insensitivity syndrome. Does anyone know what this is? And there's a famous athlete who has it. So basically, androgen insensitivity syndrome is where you're born with XY chromosomes. So you're born basically as a boy, like genetically. However, your body doesn't recognize the testosterone that you're releasing. So, and what makes males develop like penises and testes is testosterone. Their body recognizes the testosterone and develops those features. In girls, because we don't have the testosterone, we develop an ovaries and a uterus. So in androgen insensitivity syndrome, you don't recognize the testosterone that your body's producing. So you then go on to develop breasts and more like breast tissue and ovaries and a uterus, even though you have XY. So there's a scale of this. Some women will not recognize it at all. Some will have like mixed features because their body it's recognizes some but not enough. You probably don't need to know it. It's very niche, but it's something to be aware of. And I know if any of you are at UCH, they do surgery on women with this to remove their testes. So I saw some of that when I was in 4th year on my anaesthetics placement. So it's quite a niche thing, but it's quite cool. So then pathological with no secondary sexual characteristics. So this is like Turner syndrome, as I said, premature ovarian failure, chemotherapy and radiotherapy. They're important things to consider. They can stop women's because the ovaries are like rapidly dividing cells. They're targeted by the chemotherapy. And then hypothalamic dysfunction, which is what we went over before, so like anorexia and that kind of thing. And then the last one is ambiguous external genitalia. So this is things like an androgen-secreting tumour, congenital adrenal hyperplasia. I think that's what that stands for. And then that's where you have like those 17A reductase things. Does anyone know what I'm talking about? Which were like the bane of my life to learn. That's those where like they present the salt wasting in the first few hours of life.
I'll put an image in the chat.
But okay, any questions about that before we go on to secondary? Okay, so secondary is cessation of periods for more than 6 months after menarche. Anyone think of any causes? What's the most common cause of cessation of periods for more than 6 months? The most common cause is pregnancy, yes. So there's honestly, it's so important to remember because it's a waste of your time to take a history from a woman who's not got her periods and then you find out she's pregnant. So physiological causes, so pregnancy, menopause, women will stop getting periods, and also lactation, so you won't get a periods if you're breastfeeding. Pathological causes, so I've just divided these up into pituitary causes. So does anyone know what Sheehan syndrome is? Yes, Rita's right. So it's pituitary necrosis after a postpartum hemorrhage. So if you have a massive postpartum hemorrhage, your pituitary doesn't get enough blood and basically it dies. And then you stop producing, stop having periods, it affects everything else as well. So everything that the pituitary does is affected. So you get thyroid problems, you get menstrual problems, that kind of thing. And it's often picked up, it's not normally picked up at the time of the postpartum hemorrhage, it's picked up later when a woman starts presenting with symptoms of hypothyroid or she's still not got her periods back many months after pregnancy. So the endocrine causes like PCOS, Cushing's disease, hypothyroid, uterine causes like Asherman syndrome, ovarian causes, so this is premature ovarian failure, and then hypothalamic dysfunction, which is the things we went over a minute ago. And then iatrogenic causes. So hormonal contraception can cause loss of periods, radiotherapy, chemotherapy, and then drugs. So like things like antipsychotics, opioids, cocaine, metoclopramide can all cause hyperprolactin, which therefore will stop you ovulating and stop you having a period. Any questions? We are nearly done, I promise. We've got 2 conditions left and then 2 more SBAs. Okay, so PCOS. Does anyone know what PCOS is? Or does anyone know how many women PCOS affects, approximately? Okay, so PCOS is ovarian dysfunction, which is characterized by excess androgen production and multiple immature follicles, which are basically cysts within the ovaries. So my statistic is that it affects around 10%, but it's quite a high proportion of women of reproductive age. And the average age of presentation is between 15 and 35. So basically it's at reproductive age that women affect. So this is a lot of information on the slides I'm going to show. Please don't stress it out. I think you have access to the PowerPoint. Anish, do they have access to the PowerPoint?
They will, if they don't already.
So basically what happens is you have insulin resistance, which leads to high levels of insulin, which promotes androgen production, and this suppresses hepatic production of sex hormone binding globulin. And because there's less of this, there's more free androgens, so there's more free sex hormones. Does that make sense? And then the high androgen levels predispose to diabetes and hypoandrogenic symptoms, which are things like acne and skin hair growth and that kind of thing. And then there is excess LH, which is due to the increased GnR pulse frequency. It's not really sure what causes this. It's possibly linked to insulin, but no one really knows. And this excess LH stimulates excess ovarian androgen production. And then, despite the high levels of LH, the LHS is suppressed due to the increased androgens, so you don't actually ovulate. So even though you've got high levels of LH, because you have high levels of androgens, so like testosterone, you don't actually ovulate. So these women present with prolonged periods or absence of periods, difficulty getting pregnant because they are not ovulating. And basically what happens is then you get follicles which develop, so basically cysts develop in the ovaries, but they're arrested in early stages because there's not enough, because there's no LH surge, so they start to develop, but there's no LH surge, so they're just going to stop. And that's what causes cysts. Does that make sense? Okay, Seth, it doesn't. I know it's quite a lot of information, but hopefully you can look at it on the slide at a later date. Okay, so symptoms. Apart from the ones I've already said, can anyone think of any other symptoms?
Or does anyone know the criteria for diagnosing this? Because I think that's something that comes up a fair bit, right, Jess?
Yeah. Yes, it is the Rotterdam criteria. So we'll quickly go over the symptoms. So oligomenorrhea and amenorrhea, so basically lack of periods. Subfertility, so as I said, women aren't ovulating, so it's difficult to conceive. Obesity or being overweight, because you have insulin resistance, obviously that links in, and also obesity, when you have more body weight, it decreases the amount of sex-binding hormone released by the liver, which then increases the amount of androgens released. That increases the amount of free androgens, which then has the effects on LH. And then also you get hypoandrogenic symptoms, like I said before, so acne and hirsutism. And then you are right, it is the Rotterdam criteria, which has 3 parts to it, and you need 2 of these 3 to be satisfied to have a diagnosis of PCOS. So you need lack of periods, so less than 6 periods in a year, or periods are more than 5 weeks apart. Then you need clinical or biochemical features of hyperandrogenism. So this could be raised LH to FS ratio. So normally it's 2 to 3 times greater, the LH than the FH, which is something you might get like a stat and the SBA, which is like, and then you have to identify that it's PCOS. You also get raised.
They love that.
They do. So make sure you know it's 2 to 3 times LH. It's 2 to 3 times FH. You also get raised serum and free testosterone because, as I said, you get low levels of sex hormone binding globulin. You also get raised anti-murin hormone, and then the 21-day progesterone is low because you're not ovulating. If you're ovulating, the 21-day progesterone is high. And then the last characteristic is polycystic ovaries on ultrasound. So basically you have more than 12 follicles on each ovary. This is what you need for a diagnosis. The ovaries need to be 2 to 9 millimeters in diameter. And quite often you have what's called a pearl of string appearance. And 75% of women who have PCOS actually have the polycystic ovaries. But not everyone with polycystic ovaries has PCOS. That's important to remember. Okay, management. Anyone think how you manage this? Firstly, can anyone think what it's divided into, the management? Yes, but more wanting to conceive and not wanting to conceive. So if you're wanting to conceive, the first line management is weight loss. Most women, but not all women, with PCOS are overweight. So you encourage weight loss with an exercise and lifestyle changes. So you can give metformin, which will help with the weight loss, but also it can help with trying to conceive because increases peripheral insulin sensitivity, which helps with the hypothalamic pituitary ovarian axis. So not only does it help with weight loss, it's sort of shown to help with actually the chance of a woman ovulating, which is obviously the desired goal here. Then you give clomiphene, which is the thing I talked about earlier, which is an anti-estrogen. So it blocks estrogen receptors in the hypothalamus or pituitary. So it causes an increase in FH and LH, which induces the follicular maturation ovulation. So it causes ovulation basically, and helps promote ovulation that women don't experience with PCOS. So you normally give it on like day 2 to 6 and like a step, like increasing the dose every day. However, there is a risk of, well, can anyone tell me what you think the risk might be of when using this drug? Any suggestions? If you're inducing ovulation, what are you at risk of inducing? You're both correct, yes. We've had multiple pregnancies. So obviously if you're inducing ovulation, the woman might ovulate more than one egg. So you're at risk of multiple pregnancies. And you're also at risk of ovarian hyperstimulation syndrome, which is basically when you basically release too many eggs, and you get like ascites and pulmonary edema and that kind of thing. It's very rare with this, and it's more common with IVF, but it is something to be aware of. So it's much more common with IVF, but you can rarely get it with this. Then you give gonadotropes as the next line, and then as the fourth line you give IVF, or laparoscopic ovarian drilling, which is basically when you take a laser to the ovaries and you laser the ovarian tissue, and it basically reduces the amount of androgens that are produced, hoping to like restore the levels of FSH and LH, and therefore restore ovulation. It sounds quite barbaric, but apparently it works, or it can work. So if a woman does not want fertility, you can try and give her the combined oral contraceptive pill. Obviously, you have to be careful with this because there's a BMI cutoff, and some women with PCOS are overweight, and therefore it wouldn't be wise to give them the combined oral contraceptive pill. You can give them, advise them about weight loss, metformin, and also hair removal. I'm not sure if it still is, but at one point the NHS would pay for like hair removal for women with PCOS. I don't think they do anymore. So Asherman syndrome, this is the last condition, we are nearly done. Anyone know what Asherman syndrome is? It's not very common. Okay, it is basically intrauterine adhesions that partially or completely occlude the uterine cavity, and basically it's damage due to the basal layer of the endometrium. So this layer doesn't regenerate, so it like once it's damaged, that's it, and you can get scarring that forms, and the fibrosis of the basal layer, and then adhesions. So if you look at my little diagram, you can see the orange like adhesion things in the middle of the uterus. So it's caused by trauma to the uterus. So it can be iatrogenic, so D and C, which is used for termination of pregnancy, that's like dilation and cautery, something like that. ERCP, which is removal of products of like conception. Myomectomy, which is the thing I said before, where you like take a part of the uterus out, but not the whole uterus. And that can obviously cause scarring because you're like actually removing uterine tissue. And then C-sections, because obviously you're cutting open the uterus. And then infections, so like endometriosis. If you're infecting and inflaming the tissue, you can damage the basal layer of the endometrium. So management, no symptoms. You can get pain, you get amenorrhea, so or reduced menstrual bleeding, like women's periods might suddenly get a lot lighter, but they're really painful. So this is something to consider there, or they might stop getting periods completely. Or they might have struggle conceiving, so they might not know why, but they can't get pregnant. For example, they had a C-section 2 years ago and now they can't get pregnant anymore. So management, investigations. You do a hysteroscope, so that's basically where you put a camera in through the cervix into the uterus, and you look around and you'll see the adhesions. Finally, management. You do hysteroscopic adhesion lysis. So you go in again through the cervix into the uterus and basically break down the adhesions manually. You usually only do this if a woman is planning to conceive or symptomatic, because it can not work, and also you can cause more adhesions by like breaking down the adhesions and prodding with the uterine lining. So you don't usually do it unless a woman really needs it done. So complications of this are subfertility, one of the symptoms you can get, and then also obstetric complications. So you're at an increased risk of miscarriage, placenta previa and placenta accreta. Don't worry if you don't know what those are, we'll come on to them. So you're at an increased risk of those if you have had Asherman's syndrome before. Okay, SBA. So have a read of this and then try and answer it on Menti. Let me know if it doesn't work on Menti, because I don't really know what I'm doing. Also, this is a very rogue question. I just thought I'd add it in, so don't worry if you don't know the answer.
Yeah, it's one of those questions you just see once, probably get it wrong, and then keep in the back of your mind for the rest of your life. I'm not even sure I know the answer to this, lol.
Okay, so the answer I've gone with is ovarian hyperstimulation syndrome. So basically, the woman has been receiving IVF for struggling to conceive. She's developed swelling, pain in the abdomen, shortness of breath. She feels nauseated, started vomiting, and she's just received the next step in her IVF. So what I said is basically ovarian hyperstimulation syndrome is caused by an excess response to gonadotrophins. In IVF, you literally inject the woman with gonadotrophins to stimulate ovulation. So they are really high risk of ovarian hyperstimulation syndrome. And obviously you monitor it and you try not to give too many, but women will react differently to the level of gonadotrophins you release. So if you inject something in a woman, she might be fine, but a different woman may get ovarian hyperstimulation syndrome. And basically what happens is you release too many eggs and you get ascites. In severe cases, which is what this woman has, you get ascites, you can get enlarged multifollicular ovaries because you're releasing loads of eggs, you can get pulmonary edema, and then you get anuria. Unlike coagulopathies, it's very, very rare, but it's very serious if it does occur. Like, these women need admitting, they need really close monitoring, and you need to proceed with IVF, the remaining IVF and subsequent cycles of IVF with like great caution. So to try and like reduce it, you use your low dose of gonadotrophins. You can do constant ultrasound monitoring. So if you see too many eggs being released, you stop. And so it's very rare, but it's something to be aware of. So the reason I said it wasn't an ovarian cyst rupture is because you're unlikely to present with things like shortness of breath with that. You're more likely to get, yes, you could get abdomen pains and swelling, but you're not really likely to get shortness of breath. And that wouldn't necessarily be correlated with IVF. So if you didn't have a history of IVF and so no history of IVF and no shortness of breath, then that would have been my top option. Does that make sense? Because a few of you put ruptured ovarian cyst. So
yeah, I think like for exams, like if you see IVF, like this is something that should just be at the top of your mind. Why does ovarian sorry?
Because you get pulmonary edema. So I don't know the ins and outs of it, but basically you get mass like fluid shift due to the ovarian hyperstimulation. So you get ascites. So these women develop rapid ascites and they get pulmonary edema. So you basically get fluid moving into third spaces. So you get shortness of breath due to the pulmonary edema and the acute respiratory failure that you get. So they're very unwell and they become unwell quite quickly. So if you didn't have those symptoms, I would have gone with ruptured ovarian cyst. But because she's having IVF and she's got the shortness of breath, it's unlikely to be a ruptured ovarian cyst. Does that make sense? Okay, last question. Let me know if you've got any questions about this one. And then vote on the poll on Menti. Okay, so you all seem to have got this answer correct. It isn't. Oh, it's Asherman's is what we go with, or what the question is asking you. So basically, she's trying for another baby. Her periods have become irregular. That's the first clue that she's got something wrong. She suffered from an STI in the past, so she could have had pelvic inflammatory disease. You don't know. She's also had fibroids, and that's been removed. So fibroid removing if she's still trying to conceive, is a if you've got fibroids and you're trying to conceive, you do a myomectomy, as I said, and myomectomy is a high risk for Asherman's. So, and the fact that she's now struggling to conceive after having a baby before makes you think something like this is going on. Does that make sense? She's gotten, although she's had STIs before, it's a bit like a red herring in the fact that she could have PID, but it wouldn't necessarily like obstruct. You would get other symptoms for PID. And she's been struggling to conceive for the past 2 years. You're very, very, very unlikely to have PID for 2 years because it's an infection. By this point, you probably would have got septic at some point along the way or significantly unwell. Does that make sense? Anish, have you got anything to add to that? So the STIs is kind of in there as a bit of a throw off, but remember that if you're removing fibroids to get pregnant, you do a myomectomy, and myomectomy is a high risk for Asherman's.
Yeah, also, like, correct me if I'm wrong, but if you get adhesions due to PID, does that have a separate name, or do you still call that Asherman's?
I don't know. I think you can do, but it's not super, like, you'd have to have really bad PID.
Yeah, exactly. I think either way,
If you look at the time frame, she's been trying for 2 years after having you wouldn't have PID for 2 years. Does that make sense? Please let me know if it doesn't. Remember, PID is an infection, so you're unlikely to have had an infection of your pelvis for 2 years without something like becoming more unwell.
Without any other symptoms, yeah.
Yeah.
What did a lot of people go for?
Asherman's, and then we had 1 or 2 for PID.
Yeah. So, like, if you see someone with previous surgical type things, think Asherman's. If Asherman's wasn't an option here, then I would like the PID is definitely your number 2 choice out of these. Yeah. I think it's worth emphasizing, like, a really important thing in gynae. So gynae has some very typical presentations. Is it like intermenstrual bleeding? Is it dysmenorrhea? Is it menorrhagia? Like, if you can learn like a differential diagnosis for each of these presentations, it becomes relatively like simple in terms of how are you going to manage them. You can kind of like work it out if you know all of the different conditions that cause them. So like the most important thing to take away from this talk, I would probably say, is the list, these like categorizations of the causes of the different types of bleeding, because this could very easily be like a history station in your OSCE.
And you want to be able to think, right, this woman's coming with intermedullary bleeding. These are my 6 different categories I'm thinking, and then kind of ask questions to kind of rule in or out each one, if that makes sense. Yeah. So I tried to lay it out as easy as possible. Yeah. But those are like as Anish said, the takeaway things.
Yeah.
Because those are the... Go, Anish. Sorry.
As in, like, yeah, so like we have like there's these slides with all this information, and that's like we're trying to highlight what's important for you to learn, but you can go back and learn the theory in your own time. You can learn that in like the weeks leading up to the exams, but if you can come up with a list of differentials at this stage, you're doing really well.
Okay, are there any questions? Any questions about the last SBA or anything else we've gone over?
Has anyone seen any cool cases on obs and gynae out of interest? I'm going to stop recording.